I'm sure you have been enjoying this great conference organized by my good friends, Dr. Aiman Rahmani and Dr. Junaid Khan. As usual, this is 11th year and they have been keeping up the standards and it's going up every year, to be honest. And I would like to thank the speakers, especially from US and elsewhere. They have been woken up early in the morning and Dr. Neu, Professor Neu, Josef Neu is already with us. It's my privilege to introduce him now. And the session, as she briefed, is on gastroenterology. And the first topic is going to be on controversies in neonatal nutrition. All of us are focusing a lot on ventilation, but there is not enough focus on nutrition and gut health, which I'm sure it will improve in the coming era. We realize that we cannot salvage these extreme premature babies without appropriate nutrition. We had a very interesting discussion on infection in the previous session, and in Dr. Josef Neu's second talk, we will be discussing on necrotizing enterocolitis, as well as one of the common issues we face, which is the imposters. And in between, we have Professor Paulin. He doesn't need any introduction, and of course, he had a talk in the earlier session as well. So I'll be introducing him after I introduce Professor Neu for the first talk. All of you know Professor Neu as well. Josef Neu, he is Professor of Pediatrics at University of Florida in US. Extremely distinguished career. He trained in Wisconsin for his medicine, and he did his MD from, pediatric training from the prestigious Johns Hopkins University. He did his neonatal fellowship from Stanford. He had a brief stint in Switzerland. He has great interest in gut health and the microbiota, and I've been lucky to attend the Hippocrates session on this, in which we interacted in great detail. He's extremely knowledgeable, very humble, down to earth, and he can answer any question you have on the topic, and he's the expert for this session as well. So over to you, Professor Neu, and looking forward to hear the controversies in neonatal nutrition, which I'm sure we have plenty.
Well, thank you very much.
Dr. Joseph, I think you muted yourself. Can you unmute?
Okay, can you hear me okay now?
Yes, thank you.
Excellent. Okay. Well, thank you very much for that kind introduction. It's a real honor to be with you this morning, this afternoon, this evening, wherever you are. I am just going to talk about a few controversies in nutrition of the very low birth weight infant. And see if I can advance the screen here. So here we have this little 27-week preterm baby, and you can see that this baby is on mechanical ventilation, is having some distress, and the question is, how do we nourish this extremely low birth weight baby? Well, I'd like to just say that there are many, many controversies in nutrition of a very low birth weight baby. And with this half an hour that I have available to you, I'm mainly going to focus on intravenous lipids and advancement of enteral feedings, and also measurement of gastric residuals, which are certainly some controversies that we have in nutrition of these low birth weight babies. Now, when it comes to parenteral nutrition, it's very common practice that amino acids are started very slowly in the first week after birth, and they're advanced slowly in increments. That actually has changed a lot in many neonatal intensive care units. Lipid infusions are also started in the first week after birth, but advanced incrementally. And that's something that I think that there's still a lot of controversy about. And they're also frequently delayed or interrupted for various reasons. So we also have some issues with enteral feedings. There are many neonatologists who will not provide enteral feedings because a baby has had low APGAR scores. Umbilical artery catheters may be in place. The baby is having apnea and bradycardia. Baby's on mechanical ventilation, getting CPAP, vasoactive drugs. And we have TPN available, so babies can grow on TPN, but we still think that have this attitude that TPN is enough for these babies. Well, what's the concern? Well, we are very concerned about these babies developing this very distended abdomen that we see in this baby and necrotizing enterocolitis. But I can say that in terms of these excuses to withhold enteral feedings, none of them is a really valid excuse, and we will talk about that. Now let's talk a little bit about the energy stores in the fetus and newborn. And this is a very old slide from Eckhart Ziegler, but it still holds today. And if you look here at the weeks of gestation, and at the top here we see the weight, water percentage, protein percentage, lipid percentage, and energy stores. So for a 24-week gestation premature baby, the body fat is 0.1% and the energy stores are 19.5 kilocalories. The baby that I showed you before, 26, 27 weeks gestation, has about 123 kilocalories of energy stored, which is not very much. So what do we need to do with these babies? Well, one thing we need to consider is their energy requirement. If these babies are fed by the enteral route, it's been found that these babies require about 120 calories per kilo per day for growth if they are being fed enterally. If they are on TPN, no enteral feedings, one can attain a positive nitrogen balance with 60 calories per kilo per day with about 2.5 grams per kilo per day of protein. And the minimal caloric intake for weight gain is about 80 calories per kilo per day if that baby is on TPN, no enteral feedings. So you can see that these very low birth weight babies need to have energy either given enterally or parenterally shortly after birth to meet their energy needs. If we don't provide these energy needs and amino acid and lipid requirements for these babies, we can be affecting their brain development. And here we see different stages of brain development. So here's 6 months, 7 months. This is what a brain looks like in a preterm baby at 6, 7 months. Here's what it looks like at term. So there's a tremendous amount of brain development occurring during this period of time. And so early nutrition is very important. So the first controversy is how much lipid you provide to the extremely low birth weight infant from day 0. What do you do and what do others do? Well, in many cases, intravenous nutrition in the form of glucose or even amino acids is introduced early, but lipids are introduced slowly and incrementally. What is the potential problem with this? Well, we are very concerned that some of these problems may be exacerbated with providing early lipids, that we may exacerbate hyperbilirubinemia, sepsis, PPHN, lung disease, liver disease, thrombocytopenia. And I can tell you that these all have been studied very extensively. And for the most part, early lipids do not exacerbate these problems. I cannot get into all the detailed studies, but they are there. So there's also a lot of rationale for providing lipids early. And here are some of these points for providing them early. When the fetus is in utero, the fetus is getting approximately 2.5 to 3 grams per kilo per day of lipid. The essential fatty acid status in early infancy is low, and it's rapidly exacerbated if you do not provide early lipids. Long-chain polyunsaturated fatty acids, such as docosahexaenoic acid, are very important in brain and retinal development. And some of these do not get formed from the precursors in preterm babies very well. And so they actually have to be provided to these preterm babies. And you also want to provide enough energy in the form of lipid, because energy in this form of lipid prevents metabolism and spares protein. Now here we see a picture of a baby who has this scaling and peeling skin. This is a sign of essential fatty acid deficiency. And this happens to be a baby who was not given intravenous lipids for over 2 weeks. The reason for not giving intravenous lipids is because the baby had some hyperbilirubinemia, and there was some concern that these fatty acids would displace bilirubin from the albumin molecule and cause some problems. Well, that is no longer a valid concern. Several studies have been done to look at this in vivo in human babies, and that is not a real concern. We also need essential fatty acids for these babies. What are the essential fatty acids? Well, these are 18 carbon fatty acids, linoleic and linolenic acid. One is an omega-6 fatty acid. The other is an omega-3 fatty acid. And here we can see the biochemical conversions of the omega-6 and the omega-3 series into larger fatty acids, such as arachidonic acid and docosahexaenoic acid. These are very important long-chain fatty acids that are required for growth, brain development, and retinal development. Now, what happens when we don't provide these essential fatty acids to these babies early on? And this is a very old study that was done at the University of Wisconsin in 1991 by Dr. Gary Gutscher and colleagues. And what they looked at here is 4 different groups of babies. One group was receiving no intravenous lipids or no feedings, and the babies had some respiratory distress. Here was a group of babies that was not getting intravenous lipid, had RDS, but was getting some feeding. Here is no feeding, but intravenous lipid. No intravenous lipid, but feeding, okay? Here's the worst group. These babies are not getting any intravenous lipids. And what they did was they measured something called a triene to tetraene ratio in these babies, sometimes called the Holman index. And if there is a triene to tetraene ratio that is greater than 0.2, that is considered to be essential fatty acid deficiency. So I'd like you to focus on this column here. The essential fatty acid intake in these babies at 1, 3, and 7 days after birth was 0. And here we can see that the triene to tetraene ratio on day 1, the percentage of babies was 5 that had this ratio. On day 3, 15. On day 7, 80% of these babies had a triene to tetraene ratio greater than 0.2, which is telling us that 1 week of lipid-free nutrition will result in 80% of those babies having essential fatty acid deficiency, at least biochemical essential fatty acid deficiency. If you provide a small amount of lipid, 1 gram per kilo per day, you can actually prevent this essential fatty acid deficiency. There are several studies that have been done looking at mortality and morbidity of early lipids. And some of the excuses that I showed you before for providing lipids, not providing lipids, are now moot points. And here we have some meta-analyses that show no difference in mortality, chronic lung disease, or other morbidities in early versus late introduction of intravenous lipids. Now, what about the energy requirements? Well, lipids are a tremendously good source of energy. And as I said before, we need a total of 80 calories per kilo per day for growth if a baby is getting only parenteral nutrition. Now, here we have a 1 kilogram baby that we're assuming here. And if we give 8 milligrams per kilo per minute of glucose infusion, that will provide 39 calories for that baby. If we give 3 grams per kilo per day of amino acids, that provides 12. So we still need about 30 calories per kilo to get a total of 80. This means that we need to give 2.7 or close to 3 grams per kilo per day of lipids for this baby to get growth. So this is one of the reasons why it is now recommended to provide 3 grams per kilo per day of intravenous lipids shortly after birth. So when do we start lipids? As soon as possible. There are no studies that show real problems starting at 3 grams per kilo per day. Usually not more than 3 grams per kilo per day need to be provided. And prolonged infusions are what are recommended at less than 0.2 grams per kilogram per hour. Now, one question that's commonly asked is whether we should be monitoring triglycerides. And I think that this is something that was recommended many years ago, and the norms that you see recommended in textbooks are very different. Usually less than 200 milligrams per deciliter was considered to be hypertriglyceridemia. But most preterms are also being advanced on enteral feedings. And so this is a moving target. And I question what it means in terms of any kind of danger to these babies to have a triglyceride level that is 250 or 300. Because if we give an enteral feeding to a baby like this, either in human milk or formula, frequently we will see levels over 200, and we will not stop enteral feedings. So I would posit that routine monitoring is not efficacious or realistic for these babies. Now, what about these long-chain fatty acids? DHA, docosahexaenoic acid, which I mentioned before, is a product of the omega-3 fatty acid, the linolenic acid, when it gets desaturated and elongated. In the fetus, there is very high transfer of DHA to the fetus. But when that fetus is born prematurely, when we give certain forms of lipid to these babies, for example, if that baby is not being enterally fed and we are giving intralipid, we are not providing DHA for that baby. We are relying on that baby to synthesize DHA from the linolenic acid. And some of these babies have limitations in terms of their endogenous synthesis. If they are being enterally fed by the mother, we can suggest to the mother to take fish oil supplements, but a lot of these babies are not receiving that much milk yet very early on because of advancement of enteral feedings, and the babies are not getting that much DHA from the mother if the mother is not providing that milk by the enteral route. Now, when we talk about parenteral lipids, we have several different lipids available to us. One of the more common lipids is intralipid, which was used most commonly in the United States and various other countries. And here we see very high linoleic and linolenic acid content, but no DHA. There's also phytosterols, which are thought to be potentially toxic. Here is a fish oil supplement, which is omega-ben, but there's very little linoleic and linolenic acid. So the precursors for these long-chain fatty acids and the essential fatty acids are actually quite low in omega-ben, but the DHA is high. Here is an alternative SMOF lipid, which consists of soy, olive, coconut, and fish oil. very nice quantities of linoleic and linolenic, and also DHA. So many neonatal intensive care units have started to switch to a lipid, intravenous lipids such as SMOF. Now, there are some potential problems with this, and there's still some controversy about this, but there are several studies. For example, this study here suggesting safety with the use of this kind of a lipid emulsion. Okay, so that's lipids. Here's another question. Here we have this baby, again, appropriate for gestational age baby, who had APGARs of 3 and 5, has UA and UV catheters in place, and the baby's on mechanical ventilation and getting prophylactic indomethacin. Can we feed this baby using the GI tract? What are the consequences of not feeding this baby? And how do we feed this baby? How do we advance enteral feedings in this baby? Well, I show you this picture of Elsie Widdowson because she did some very important studies in piglets over 60 years ago. And one of the things that she showed in her studies in piglets was that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If that piglet is not suckled, if you do not put any food into the gastrointestinal tract, what happens? The gut does not grow. And this has been supported by numerous animal studies over the past several decades, that no food in the gastrointestinal tract, you do not get a trophic response, even if you are giving total parenteral nutrition. Here's an interesting slide from a classic study that was performed at Baylor University a couple decades ago. And this was at a time when babies were frequently not provided enteral nutrition for weeks, sometimes 2 or 3 weeks after birth. And what they were able to do at that time was look at babies who were getting enteral nutrition in the first 2 weeks versus no enteral nutrition. So TPN only versus a small amount of enteral nutrition starting at day 4. And these were babies that had a mean birth weight of 1 kilogram, gestational age of 28 weeks. And what they did was they gave these babies lactulose and mannitol. And lactulose and mannitol can be measured in the urine, and that can give us an indicator of permeability of the gastrointestinal tract. So in other words, another way to look at this is leakiness of the gastrointestinal tract, where the tight junctions between epithelial cells are open. If the baby is getting only TPN, no enteral feeding, to day 15, on day 10, we see a greater permeability than if that baby is being fed enterally. So putting food into the gastrointestinal tract prevents this leakiness of the gastrointestinal tract. What does this leakiness do? Well, if you have an opening between the junctions of the intestinal epithelial cells, that will allow antigens, microbial products to get through and to incite an inflammatory response in the gastrointestinal tract. Here's another study that was done at by the Harvard group by Dr. Konnikova, working with Cami Martin several years ago. And they looked at early enteral feedings versus late enteral feedings. And they measured certain outcomes such as NEC, retinopathy, chronic lung disease, PVL, IVH. And early feeding was prior to 4 days versus greater than 4 days. And if you look at the univariate analysis of these comorbidities, you see much greater comorbidities in the babies who were fed late. In this study, at 2 weeks of age, they also evaluated inflammatory mediators in the blood of these babies. And they found that those late fed babies had considerably higher pro-inflammatory mediators in their bloodstream than those fed early, supporting what I mentioned just previously, that tight junctions are more open and you can have a greater pro-inflammatory response. We also now have more studies that suggest that increased feeding advancement is totally safe in these babies, in many of these babies. Here's a study that was done in UK, controlled trial of 2 incremental milk feeding rates. One milk feeding rate was 18 cc's per kilo per day, increment per day. The other was 30. And what they found in this study was that there was no significant difference in survival in moderate or severe, without moderate or severe neurodevelopmental disability at 24 months in these very preterm babies. They also saw no difference in necrotizing enterocolitis or late onset sepsis in these 2 different feeding advancement groups. Then the last controversy has to do with measurement of gastric residuals. Here's the question. You're on call at 2 o'clock in the morning, and the nurse wakes you and reports that this baby who is being fed 2 milliliters of breast milk every 3 hours is having 2 cc's of gastric residuals. So what do? Tell the nurse not to bother you at 2 a.m. in the morning? Stop all feedings? Ask about the physical exam and perhaps examine the baby yourself? Well, this would be the nice question, nice answer for this question. But the question here is, should we even be doing routine gastric residuals in these babies? Think about this. If a baby is being fed enterally by tube every 3 hours, and if a gastric residual is measured, and if you throw away that gastric residual because it looks a little bit greenish or it just doesn't look right, you are taking away precious gastric acid and also peptidases that the stomach of this baby has been producing. You also, with the suction, may provide a little biopsy to the gastric mucosa each time a gastric aspirate is done. So this is something that was very concerning to us. And so we did a couple of studies, and this is the most recent study that was reported from our group at the University of Florida, looking at, this is a prospective randomized trial of measuring gastric aspirates versus not measuring gastric aspirates. I'm not going to show you all the data, but I'm going to give you the results of this trial, and this result suggests that evaluating gastric residual is unnecessary and may decrease the delivery of enteral nutrition to extremely preterm infants. Limiting gastric residual evaluation to infants with symptoms of gastrointestinal dysfunction, including abdominal distension or tenderness, emesis, and clinical decompensation or bloody stools, may increase enteral nutrition delivery in this vulnerable population. And we have now translated this to evidence-based practice in our neonatal intensive care unit, and we are no longer measuring gastric residuals routinely. And I think that many other neonatal intensive care units have gone to not measuring gastric residuals routinely. So I'd like to stop here with some take-home messages. Early nutrition in preterm babies can be safe and efficacious and may prevent significant morbidity. Growth is important, but we also need to consider long-term neurodevelopment and other health consequences. Many of the dogmas that have prevented rapid incorporation of early nutrition have either been disproved, not based on fact, or weak. And not all preterm infants are the same. And in the future, we're going to need to focus on a more personalized approach that accounts for specific gestational age and degree of illness, and also omic considerations. And I'll talk about that a little bit in my next lecture. Thank you for your attention.